Hi everyone, this is Abby Ferdinand, PGY2 Oncology Pharmacy resident, and for today's Clinical Pearl, I wanted to present on some of the new NCCN guideline clinical updates for pancreatic cancer that were published at the end of October 2020. Overview of pancreatic cancer. These were estimates from 2018, specifically within the United States. It was estimated that 55,440 people will be diagnosed with pancreatic cancer during that year, and approximately 43,330 people will die of the disease. Pancreatic cancer is the fourth most common cause of cancer-related death, and something that's really interesting to note is that increasing participation in clinical trials is really needed and critical to making progress in this disease. Currently, only about 5% of patients actually do enroll in a pancreatic cancer trial. So it's really important that we bring awareness to this topic and really advocate for clinical trials if we do have patients that are appropriate and there is a clinical trial that is available. Moving into some general principles of treatment, systemic chemotherapy is used in all stages of pancreatic cancer. This actually includes neoadjuvant therapy, both for resectable or borderline resectable disease, as well as adjuvant therapy and first-line or subsequent therapy for locally advanced, metastatic, and recurrent disease. Again, the guideline authors do note repeatedly that enrollment in a clinical trial is going to be strongly encouraged if we want to further make progress within pancreatic cancer, to find new therapies that are beneficial for patients, and also for gaining a better understanding of the disease and how it can progress. When looking at the preferred chemotherapy regimens, the principles of therapy is largely going to depend upon the patient's performance status. So if they do have a better performance status with an ECOG of 0 to 1, for example, we likely can be very aggressive in choosing a regimen such as FOLFIRINOX, versus those patients who do have a poorer performance status may have to do something like gemcitabine monotherapy, for example. Really, FOLFIRINOX has a role in all stages of pancreatic cancer, even in locally advanced disease as well as metastatic disease. FOLFIRINOX, or modified FOLFIRINOX, plus or minus subsequent chemoradiation, is one of the preferred regimens, as well as gemcitabine plus albumin-bound paclitaxel, plus or minus subsequent chemoradiation. And then finally, for patients who have known BRCA1 or 2 or PALB2 mutations, FOLFIRINOX or modified FOLFIRINOX, plus or minus subsequent chemoradiation, or gemcitabine plus cisplatin for 2 to 6 cycles, plus or minus subsequent chemoradiation, are some of the preferred regimens. Being that FOLFIRINOX is utilized so heavily throughout the treatment of pancreatic cancer, I did want to review this treatment regimen and go through each of the agents individually. FOLFIRINOX consists of oxaliplatin, dosed at 85 milligrams per meter squared, administered over 2 hours, leucovorin calcium, dosed at 400 milligrams per meter squared, administered over 2 hours, irinotecan, dosed at 180 milligrams per meter squared, administered over 90 minutes, and this is given 30 minutes after the leucovorin infusion. Finally, fluorouracil, both the IV bolus and the infusion. The bolus is dosed at 400 milligrams per meter squared, followed by the continuous infusion of 2,400 milligrams per meter squared, given over 46 hours. This cycle is repeated every 2 weeks until disease progression or unacceptable toxicity. 12 cycles is recommended for patients who do respond. So again, this regimen is utilized really heavily. However, as we talked about prior, this is a rather intense regimen, and patients do need to have a really acceptable performance status in order to be able to tolerate this. But one of the really interesting and unique things about this is that with FOLFIRINOX, we are really going for curative intent in those earlier stages, which is something that's really exciting for pancreatic cancer, being that before or prior in history, we did not have a lot of great treatment options. Now moving forward within the guidelines, I want to focus on what has been updated or what's new with the newest pancreatic cancer guidelines. First in the what's new section, PARP inhibitors. Now olaparib is recommended only for germline BRCA1 or 2 mutations, and this has moved from useful in certain circumstances to a preferred regimen. Also, for certain regimens, they have moved from useful in certain circumstances to other recommended. These include capecitabine, gemcitabine plus nab-paclitaxel modified schedule, category 2B recommendation, as well as gemcitabine single agent, category 2B recommendation. FOLFIRI was removed and replaced with 5-FU plus or minus irinotecan. FOLFOX moved from other recommended regimens to useful in certain circumstances. 5-FU plus or minus irinotecan may now be considered for maintenance therapy in the case of oxaliplatin-related progressive neuropathy or allergy to oxaliplatin. And there also was a footnote added that while FOLFOX is not commonly used in the maintenance setting, it may be considered as an alternative to irinotecan-based therapy when GI toxicity is of concern. I also did want to talk about Keytruda or pembrolizumab. Although this recommendation itself is not new, I did want to talk about pembrolizumab as it seems it is gaining a lot of traction in a wide variety of malignancies, including pancreatic cancer. For pancreatic cancer, it is recommended only for microsatellite instability high or DNA mismatch repair tumors, specifically in the locally advanced or metastatic disease settings. What is new with this update is they did add a reference from Maribel and colleagues, and this trial was entitled Efficacy of Pembrolizumab in Patients with Non-Colorectal High Microsatellite Instability Mismatch Repair Deficient Cancer, and these were results from the Phase 2 Keynote 158 study. In this trial, 233 patients were enrolled, with 27 different tumor types represented. The most common tumor types were endometrial, gastric, cholangiocarcinoma, and pancreatic cancers. The median follow-up was 13.4 months, and the objective response rate was 34.3%. This had a 95% confidence interval of 28.3% to 40.8%. The median progression-free survival was 4.1 months, with a 95% confidence interval of 2.4 to 4.9 months. And finally, a median overall survival of 23.5 months, with a 95% confidence interval of 13.5 months to not reached. So obviously some really impressive results that came out of this trial. To conclude this clinical pearl, I did want to mention that November is Pancreatic Cancer Awareness Month, and there are many different groups advocating for and bringing awareness of pancreatic cancer to communities and nationwide. Some websites that you can visit for information include pancan.org and pancreatic.org. And this really is a month of empowerment, education, and inspiration for our community to really bring awareness of this disease. It also is important to know the signs and symptoms of pancreatic cancer. These can include abdominal or mid-back pain, loss of appetite, jaundice, weight loss, nausea, change in stool, and finally, recent onset diabetes. And again, as previously mentioned in the beginning of this presentation, we need to continue to advocate for clinical trial involvement for our patients in order to continue our progress and knowledge of pancreatic cancer. As always, if you have any questions, please feel free to contact me, aferdinand@monument.health. Thank you.